Good afternoon. It is my great pleasure to welcome you to a very special Medical Hour webinar with Kate Bowler and friends entitled No Cure for Being Human, Reimagining Care in the Midst of Disappointment. My name is Karen Wright-Marsh, and I am the Executive Director of Theological Horizons, a community and campus nonprofit that supports Christians and seekers by providing a welcoming community for engaging faith, thought, and life. I hope you'll accept my invitation to explore our mission, our programs and resources, and join the Theological Horizons community. This webinar is part of the inaugural Scoper Lecture Series in Christian Thought, made possible through the generosity of Dr. Stephen Scoper and Ms. Nancy Scoper. If you missed yesterday's incredible lecture in Old Cabell Hall, I hope you'll join us at 7 p.m. Eastern this Thursday, April 7th, for the online video premiere of Kate Bowler's talk, Unfinished, The Wisdom of the Generative Self. You can find details at theologicalhorizons.org. The next hour will unfold in this way. Our facilitator, Dr. Stephen Scoper, will introduce our presenters and open the floor to Dr. Kate Bowler to frame the conversations. Our four panelists will briefly respond in 2 or 3 minutes and then enter into conversation with Dr. Bowler and with one another. And to those of you joining us locally from Charlottesville, from the medical community, know that we have not forgotten our promise of lunch, so those vouchers will come to you following the event, and we hope you'll watch your inbox for that. We are honored and so grateful to present this webinar with our partners, UVA's Center for Health, Humanities, and Ethics, and Hospice of the Piedmont. Thank you. Dr. Scoper, it's all yours.
Thank you, Karen. It's a pleasure to be here with all of you guys today. And thanks again to Kate Bowler for being our guest over this weekend. As Karen said, I'm Dr. Steve Scoper. I'm a past faculty member at the University of Virginia. I was assistant professor of ophthalmology in the Department of Ophthalmology and the program director. I've been in private practice for a number of years in Norfolk and Virginia Beach, and on faculty at Eastern Virginia School of Medicine. So it's nice to be back home in Charlottesville at the University of Virginia Medical Center. So welcome to all of the medical professionals who are on this call today. And it's been very exciting to have Kate Bowler from Duke. And as most of you know, Kate had a diagnosis of stage 4 cancer about 5 or 6 years ago. And through her first book, Everything Happens for a Reason, and Other Lies I've Loved, starts that story, that very compelling story. And I would encourage you to look at this book as well as her latest book, No Cure for Being Human, and Other Truths I Need to Hear. In her talk yesterday to a full house at Cabell Hall was very compelling. All of us know that medicine is different than it was just 2 years ago. The pandemic has changed everything, whether you're working in the emergency room, working in oncology, or as an ophthalmologist who can't hire enough staff to see the patients. It's a whole new world, and it can be very disappointing for the doctors and staff as well as the patients. And so that's why we have this topic of reimagining care in the midst of disappointment. So Dr. Kate Bowler, let me hand it over to you. We're so glad you're with us today.
I'm so glad to be here, and which you will describe them in a moment, but the gorgeous insights of the panelists. I'm just really thrilled. I was trying to think of what we share and what might be a lovely way into the friction of this moment, and it made me think a lot about cultural scripts, scripted ways of interacting, of being human in medicine, and the area of my expertise, which is of American self-help and the account of the endlessly positive self. I know we always we bump into it with friends and patients, and but there's this moment in our conversations where we start apologizing. Thanks so much for listening this long. Sorry, I know this is a lot. well, I shouldn't be telling you this all. It's so depressing. Someone needed a listening ear and you sit close and the story starts to unspool. I didn't want my life to be this way. I don't know how I'm going to move forward. I'm so scared. But for the moment, it feels embarrassing, isolating, costly somehow. I was sitting with a friend recently who was very sick and just had a sudden, very complicated breast cancer diagnosis. And she was struggling with treatment that had left her skin sallow and thin, and she was struggling to get out of bed. And her head was all fuzzy and patchy, and she'd lost all of her beautiful mermaid hair. And she was looking at me with her giant Disney eyes. And there's a moment there where the thing between us is the feeling of a living death, and that she wants to spare me. And that she is in that moment beginning to believe that it is too much, that she is too much, that maybe she is the bad thing. And it reminded me of just how difficult this translation can be between what Susan Sontag calls the kingdom of the sick and the kingdom of the well. That in the kingdom of the well, I find it to be dominated by the kinds of invincibility narratives that I see in cheap paperbacks available at any Target or airport kiosk, that you are a conquerable project, that there will always be enough, that there are silver linings everywhere, that if you just believe it in your bones, that things will get better. Any setback is just temporary. Hope is just around the corner. Everything will add up. And even our language about pain imagines that things, that nothing is lost, right? And then there's this other world, the one that Taylor describes so beautifully in her gorgeous book. I hope you all read This Boy We Made. And she has this gorgeous quote. Taylor was thinking about you yesterday, the one where you say, when we talk about befores and afters, well, here's the thing about afters, is sometimes they can last forever. And in the kingdom of the sick, and we know this kind of fellowship where you're the one who's gotten what I always think of as kind of like Cocker Spaniel face, with people's heads tilt slightly to the side, and you can tell from across the room that they know, they know that you're the person who knows. You have to ask for a certain blood worker by name or to call their supervisor because you could find a vein better than that, or that you're nervous the second you see certain numbers on your telephone and hold your breath when you get the email notification that your test results are there. That is somewhere between the kingdom of the sick and the kingdom of the well. In American culture, part of what has exacerbated the space between it is that our popular cultural idioms around being well forces the price of admission for sick people that we must. I think this all falls under the kind of some of the cultural scripts we have around the good patient. Right now, I think much of the good patient narratives are dominated by forcing the kingdom of the sick to pretend they are well in order to hope for the care they long to receive, that they can be seen as plausible narrators of their own circumstance, that they are cheerful and positive and approachable in the right way. Sometimes looking back over the 4.5 months that I spent trying to convince caregivers that I didn't just have stomach pains, but that I had something much more severe, something that over the course of those months were eventually diagnosed as an enormous series of tumors in my colon, but that I was so it pains me to think of how cheerful I imagined that I needed to be, how much shame that I internalized, that I can see when I look in my friend's suite. moon face shining back to me when she wonders if she is the bad thing. So given that this incredible panel understands what it means to carry dual citizenship between the kingdom and the sick and the kingdom of the well, I thought maybe we would start there with the places in which you notice the most, the greatest lack of translation between these two kinds of people, and how in your work that you've discovered ways of building a bridge between them, that you belong to both. I can't wait to hear.
And thank you so much. Thank you so much, Kate. I'm now going to briefly introduce our four panelists all together, and then we'll start with Kate, with Taylor first. Taylor Harris is, as Kate already mentioned, is the author of the really highly acclaimed memoir, This Boy We Made, as well as many articles in the New York Times, Time, Parents, McSweeney's, the Washington Post. Very well written, and so a former board member of Theological Horizons. So Taylor, we're so happy to have you. Anne-Marie Smith is currently serving as the adult oncology chaplain at the Emily Currick Cancer Center. And this is a career which grew out of her experience with cancer back in 2008. So Anne-Marie, we're really so pleased to have you with us. Tyson Bell is Assistant Professor of Medicine in the divisions of Infectious Disease and Pulmonary Critical Care Medicine here at the University of Virginia, and Director of the Medical Intensive Care Unit. And I think, Tyson, you are on call in the emergency department today. So we hope that you'll have a few minutes to talk to us, and we thank you for all of your hard work in the midst of this pandemic over the last couple of years, and look forward to your comments. And then finally, Tim Short is the Chief Medical Officer and Director of the Education Institute at Hospice of the Piedmont, and a former, before that, Associate Professor of Medicine and Palliative Care here at the University of Virginia. So we've got four people from different backgrounds who are going to bring a lot of input here. So Taylor, welcome.
Thanks so much for having me. So there are so many ways to come at this question, and I would really just like to say I'm honored to be here, and I would sort of like to carry everybody with me in my pockets. I feel like I could show up to any appointment if I just had all of you with me. But I just want to say, I thought there are two ways to think about disappointment. So I think on one hand, there's the disappointment we feel almost like on a cellular level in our bodies. Like Kate mentioned, the before and after. So for me, or for even caring for my children, it might be, I thought my body worked in this one way. Turns out that's not right. It works in this other way, and I'm not very happy with it. And from there, you might go into theology, and maybe you ask God, why, or what does this mean, or what do I do? And so I think that disappointment is very real. Actually, the disappointment I want to focus on a little bit more today with my time is disappointment in or concern about the care you receive as a patient to actually address that problem in your body. And for me, as a Black woman, I carry both when I walk into a room. And so I think Kate's comments about cultural scripts is actually really relevant. I wasn't sure how this would all fit together, but I think we'll listen back and hopefully find that it does. I want to start with some words by a writer named Rose J. Percy. These words have captured my imagination lately. She writes, "Be careful where you take your steps in that place. They did not build it with your face in mind." And so that's something that I bring with me when I come into a room. If it's Charlottesville, sure, but also other cities in our country, other rooms. To give you an example, I had 2 of my 3 babies in Charlottesville, and I had great experiences. So hear me, I had great caregivers. But when you walk into the maternity ward of one of the hospitals, there's a mural, and it's of 7 people who presumably sort of help make a hospital go. And there's one Black person on the mural. It's a Black woman with natural hair that's short, and she is holding a broom. And this is the place where I was told as a Black woman would be one of the best places to have my baby. They described it as a hotel, which is weird because having a baby is not like a stay at a hotel, but I get what they were saying. But this is what I'm greeted with when I walk into. And so I think what Ross Gay, a poet, calls it a corruption of the imagination. So when I go into these spaces, instead of all of my energy going into, having a baby, caring for my child, caring for myself, I'm spending time on, well, if that's what that Black woman means to people who work here or to the person who hung the mural, how am I seen, right? And so that's hard to get away from. And I also walk in knowing that Black women have a higher rate of complications and death, even when having children. I walk in with stories of friends who really needed acute medical care and were almost sent home because it was assumed that they were using drugs. And so these are the things that I bring with me when I come into a room. And so I think that there's got to be a change in our collective imagination. I think it will cost us. I don't really do numbers and dollars and cents, but I think that it will cost us to change the way that we listen to patients, the way that we are. I know that doctors have to be efficient, but it's hard for me I don't want someone to listen to my story and quickly fit me into a box or to a narrative. Even reading Kate's story, we know that a lot of women experience medical gaslighting. And when she's explaining in her book how she had these terrible symptoms and she kept getting turned away, I was so upset. And it's something that I can relate to. And that's really scary. And so just quickly circling back to that picture of the Black woman holding the broom, I had surgery 18 months ago. And had some complications right after that were pretty traumatic and scary, or my blood pressure tanked. I had tachycardia. I had a reaction to a medication that was used. And when I think back to those scary 4 or 5 hours, there's my husband there with me, but there's also a Black woman at my side. And, they take my contacts out for surgery, so I can't even really see her. And everybody's wearing masks for COVID. But she's got, short, natural hair. Her name is Anika. And she refuses to leave my side. And she grabs my hand and she even hollers out down the hall, like the sweetest words I've ever heard. She's like, "Tell them I'm not coming. I won't leave her side." And she says, "Taylor, tell me about your children." And when another doctor comes in and they say, "Well, there's nothing we can do about this reaction. You have to let it go out of your system." And I say, "Can I get something? Because I'm really nervous and shaken." And they say, "No, we can't give you anything." It's Anika who runs out, somehow finds another doctor, gets an order for some medication so that while my heart rate is 150, my mind also isn't racing. And so I don't think the answer is just to have more Anikas, even though that would be great. But I do think we need to reconsider how we hear people's stories and how we believe them.
Thank you so much, Taylor. Anne Marie, welcome.
Thank you, Taylor. I will admit that just even hearing the stories and the sharings has kind of shifted what I initially thought I wanted to say. And I think maybe the first thing that comes to mind now is how we kind of think of a healing in medicine. And we tend to think of it in a very small way, like healing is not being sick anymore. But the fact of the matter is that a lot of healing can come in tandem with a terminal diagnosis or knowing someone's going to die. Healing relationships can happen. And the other thing I feel like I certainly experienced myself is that what we think of as bad news, which is in fact often bad news, can also be paired with a reevaluation of how you're living, how you're spending your time, who you're spending your time with, and what you kind of what your values are, even an opportunity to look at those values. And that is in fact very healing. And so I hope that we will include a wider understanding of healing in medicine. Another thing I was really struck by yesterday that I thought of again in my own experience, but then also in spending a lot of time with families and patients who've gotten bad news, is the importance of being seen and seeing someone. And Kate, I think, alluded to this yesterday too, but I think when someone is hurting, and that happens in all sorts of ways with bad news in medicine, that we're particularly vulnerable and feeling very alone. And so if another person can take the time to see you and to see your pain and acknowledge it, that is very affirming in our humanness and our ability to connect with one another. And I think we think that we don't have time to do that in medicine, but in fact, those moments of seeing one another happen in an instant. They happen in a deep breath or in a pause or grabbing a hand. They generally are not things that are long conversations even. They're very brief, and how important that is. And in thinking of that, having been a patient and then also being in the medical setting, what I've come to realize too is that all of you all on this call are probably tied to medicine in some way, and we think that's something we want to offer for our patients. But I would argue that it's just important for the clinician to make that connection, to see someone and know that person feels seen is a big part of a clinician's humanness as well, and that it's quite important. And then the other thing I've really been pondering since hearing Kate yesterday is what perfectionism looks like in medicine. And I think often it looks like thinking that death is a failure, not being able to cure is a failure, when in fact, like suffering, old age, death are just part of our humanness, and not to label them so much as good and bad, that they just are, and how to be with that with people. And I think, if we start to thinking of that as bad or separate from the human experience, I think we bring in kind of feelings of guilt and shame, which are isolating yet again for our clinicians and for our patients. So how to be with that people and take away that kind of dualistic thinking. So those are some of my thoughts. Thank you all so much.
Thank you, Anne-Marie. Very powerful things for physicians to hear. We need to hear those things, and other healthcare workers. So thank you for those insights. Dr. Tyson Bell, welcome.
Hi, and thanks for having me. And first of all, let me just say, Taylor Harris is basically family to me. My kids call her auntie. My daughter wears hand-me-downs from her daughter. And I've known her since 2001, I believe, here at University of Virginia. We were undergrads, and I'm just so excited that the rest of the world is beginning to understand what many of us who have known her for so long have already known, and just how fantastic she is. And so I'm excited for this moment and for her moment. I'm also excited that we get to borrow a little bit of Kate Bowler's time. She has a fantastic reputation, has done so many interesting things, and has touched so many lives. But you get the sense of the humanness of her and her sense of humor, which comes out readily. I just met her yesterday, and within 30 seconds, I was laughing beside her, taking an awkward photo. And it's moments like this that it's the human connection that happens sometimes, that can be fleeting, but it's so significant when it happens. And a lot of what's resonated with me, Kate mentioned this yesterday, and let me just say this: we all say, there's a recorded lecture that you can look at later, and we say, yeah, give me the link, give me the recording. We never look at the recorded lecture later, right? This is actually a lecture that you should find and look at later. It was that good. I went home and told everyone about it because it was so impactful, really, from beginning to end. It was just a great event. So you actually need to look at this recording. But I digress. What's resonated with me the most over the past day or so has been this concept of existing between two poles, what Kate mentioned yesterday, two poles, one is everything and one is nothing, or the kingdom of the sick or the kingdom of the well. And we tend to think of things in binary terms. What we have most of the time is what exists in front of us. And I thought about this when I was a very happy moment. I officiated my brother-in-law's wedding, and I said in the ceremony, in the rich context of our lives, the things that we've done, the places we've been, we've all converged on this moment to marry this couple. And similarly, when we're in the hospital or in the clinic, in the rich context of our patients' lives, we intersect in a moment in time and place. And sometimes that moment is just a moment and we may not see that person again. And sometimes it's in continuity. And for whatever reason they're seeing us, oftentimes it may not be for a good reason, but they're always in this in-between space for whatever issue that they're dealing with and on this continuum. And when there's so much flux in what patients are going through and what we're going through, the only constant in those relationships is that human connection. That's really it. And at the end of the day, what resonates with patients is how they feel after they interact with one of us. And we know this, right? Because when we've made that connection, when we've been patients on the other side, we understand it. But it's hard to do, and it's hard to do for many reasons. But two of them I'll just mention. We often can jump between extremes in a matter of minutes. There are days when I may be in a patient's room who's not doing well, has a bad prognosis, and we're talking about disconnecting from life support. And I may go into the next room where there's entirely different story and there's happiness and joy, and we have to be available for both of those situations fully, ideally. And then the second reason is that, there are the walls of the hospital and the clinic, but there are also the walls of our own homes and the context of our lives. And we have to be emotionally available for our own families as a part of being a full person. And I remember the most violent transition I ever had was in the MICU when I had a patient who was full-term pregnant, had a fall, had a hemorrhage in her brain, and unfortunately passed away from brain death. And we delivered her baby in the ICU. Incredibly sad situation. I drove in for it, and I was in the hospital for a few hours between 3 and 8 a.m. And then I drove home, and like many of our children, our children do not let us have a gradual on or off ramp. It's on and popping when you get home. And so when I got home and walked through the door with all this weight, my daughter has just climbed the stairs in our home for the first time without needing anyone to help her. And she's so excited and so jazzed up. And I'm trying to meet her at that moment, but I can't quite get there. And my kids could probably, not tell the difference, but my wife certainly could. And she asked me, what happened at work? And so that is very difficult to do. And we all have our different ways of coping with this, right? And dealing with this. There was a story Kate told yesterday of an ER doctor who gets funeral notifications. And he says, I never go to those. I'm just a tourist. A very hands-off sort of approach where we know what's happening. You're kind of erecting a silo so that you can, keep what's happening at the bedside, completely separate from what you're doing and disengage. And that's how you maintain your mental health and sanity, and may be effective, but it also feels kind of wrong, right? It also may feel wrong to go completely to the other extreme. We can't mass produce a bunch of Anikas. That would be great if we could, but Anika may have been called to see another patient, or may not have the time to dedicate for whatever other reason. And so sometimes that's not possible either. And so we all have our different solutions. And for me, my staff and I talk about this a lot. COVID has really exposed how devastating the process of taking care of patients can be for us, because this was a moment where we had that human connection, whether we wanted to have it or not, because we were all going through it at the same time. And so it exposed all of us and all of our mechanisms and shortcuts that we use to get around this and deal with it. And so we've had more of this conversation recently, but everyone has their different methods. And for me, actually it's talking about this and calling it out and just, calling a spade and saying we are not well, we are not okay. But in order to maintain and show up for our patients and build that human connection in those moments and be that constant in the midst of so much flux, that is how I imagine healthcare reinventing itself, coming out of the last couple of years. So I'll leave it there, but thanks for having me.
Thank you so much, Tyson. We so appreciate your thoughts. Dr. Tim Short, welcome.
Thank you. Thank you. Kate, I have to tell you that phone call and the walk after that phone call has haunted me since I've read about it. For those of you that don't know or haven't heard her story, she got news of her stage 4 cancer while in her office and then was told to get to the hospital right away. And the Duke campus is formed like a big cross with the chapel at the head of the cross, and her office is on the right side of that chapel. And if you walk down and turn left on that left arm of the cross, it dead ends into the Davison building, the old entrance to the medical school. And it haunts me because nobody should get that call alone. Nobody should make that walk alone. And I made that walk numerous times as a religion major as an undergrad at Duke. And my apartment was, I cut through the medical center to get to my apartment. So I made that walk every day for a number of years. And I made that walk figuratively as moving as an undergrad religion major to a medical student at Duke as well. And you know better than as well as me, that right when you get towards and close to the medical center, there's a set of stairs. And they're worn, like all the stairs around Duke. There's grooves in them that almost invite you up the stairs. They beckon you up the stairs. They almost make that climb a little less daunting. But every time you go to that and make that walk and you climb up those steps, there's a momentum that carries you forward. And there's a momentum in our medical system that carries people into the bowels of our hospitals on a conveyor belt. And the default of the system is to do everything as aggressively as possible. And that's a good default for you, Kate. That's a good default for a lot of people that have a lot of living left and are going to benefit from that. But at some point, sometimes that conveyor belt spits you out in Tyson's ICU, doing things that are harming more than helping. And having the wisdom and knowing, hey, when do I step off of this? And us listening to people to say, hey, I want off of this. That set of steps, that up climb, is kind of the intersection that I think Theological Horizons focuses on. It's the intersection of faith and thought and life. It's the intersections where are you striving or are you surrendering? It's the intersection where you're trying to live with a life-limiting illness and hold on and find hope and live in that suspended life as you talk about. And I think for we as a medical community, we tend to, when you step in those arched doors in the Davidson building, they look like the chapel doors. They're beautiful, big wooden arched doors. But then you step into this chaotic maze of buildings that have been connected to other buildings. You don't know your way around there. And when we're done with you, we'll walk you back to those big arched doors and we'll stand at the doorway and we'll send you on your way back to the gray building, back to your office. And we'll watch you navigate those steps. But I wonder what it would be like if we'd walk out with you and join you at the top of those steps. That's what palliative and hospice providers, that's what good medical providers in general will do. They'll walk the other way with you. our hospice just went through an intensive process of kind of looking at who we are and what we do. And we distilled it down to 3 words: strength, presence, and purposeful. And I'd like to kind of create an image, if you will, together here, where Kate, we hold on to you and your wobbly legs and those feet that don't really know where they're landing anymore. And we go down those steps together. And we take a couple of steps, and suddenly language moves from neuropathic pain to suffering, and what it means to you and how it's limiting you. And not just the physical suffering, but the emotional, the relational, the spiritual dimensions of that suffering as well. And we take a few more steps in that shared strength and purpose, and we find the questions even begin to shift from, what's the scan show? What's the prognosis? What's the horizon? To why? Why me? And we get to the bottom of the steps where we can truly be present to you, where we can hear from you what's important to you now, and is your treatment offering and supporting that? And you can hear honestly from us in our best estimate, what's your horizon look like? Because you need to know, am I going back to my office? Is my best work still ahead of me? Or do I want to make a hard left and go down to the gardens and sit at that fish pond with my little boy and my husband? That is the task, I think, that we all in medicine are called, not just providers, physicians and NPs, LIPs, but all of the team, to go down the up staircase with you, hold on to you, and be grateful that you're holding on to us, because you're doing that in an incredibly powerful and transformative way, Kate.
Thank you so much, Tim. Go ahead.
That isn't the most pastoral word I've ever received. I don't know what is.
I know. So Tim, I had a question for Kate, and you just set me up perfectly. Kate, you do such a powerful job talking about the kingdom of the sick from a patient's perspective. But when you look at the kingdom of the sick with all these healthcare workers, with these doctors and nurses and healthcare workers on this, when we are looking at a patient with illness, chronic illness, death, what can you say to us as doctors and nurses and healthcare when we are also in the kingdom, when we're at work, we're in the kingdom of sick as well. And we also realize that there's no cure for being human for us as well.
My word. I mean, what a gorgeous conversation. There's so much beautiful language here for that liminal space, right? Taylor describing the betweenness of then the messages she gets coming in, and whether that will impede her feeling of safety and care, and Anne-Marie describing the loaded language around suffering, and whether that too makes our humanity feel like an affront instead of just a progression of our finitude. And Dr. Bell going home and having no liminality, just a series of gears, like first to fifth, then back to third, and then and how few places there are. I just for the space between. Tim, that description of the office to the hospital, that is a gift to me. I will keep that. I'll keep that, because that was the worst walk of my life, because it was the place where nothing made sense, but it was the feeling of being sucked into. I remember I had to call my family on the way, and we were all so confused. My mom said, I'm just like, hey, because it's first to fifth. And she said, oh, but you can, oh, sweetie, but you can give us SAC. oh, don't worry, you can give us your son, because everyone is confused in the hurricane of between, that every out of order thing has made every act of love strange. And I remember just trying to explain, like, oh, mom, Tobin, my husband's still alive, like they can. That feeling of between. I hope it's nothing we ever forget when we look into the eyes of all those who are like us in those moments, who don't know, who just don't, who need the miracle of the person who reaches out for our hand, who can't secure for ourselves the conditions of our own independence anymore. And I remember sitting in that intake room before that horrible lady who made the phone call, who the next week explained to me, she was my age, that the sooner you get used to the idea of dying, the better, she said briskly, as if she'd never met someone who just had a world come to an end. And I told the doctor when they came in, I said, I have to admit, I'm just bracing between what's just been said. And she said, oh, I mean, she would never say something like that, because of course we know each other as colleagues. We know each other as, it's so difficult to be back in that bleary, confused, upside down world where you find yourself saying to a doctor, you better be holding my hand if you're going to say something like that. And there's a weird, I mean, you know me, there's not a formula that undoes the work of pain or makes it worth it in any fundamental way. So I tim your account of suffering as that people would walk you in and walk you out, that we kind of graduate into the different ways of being limited with one another, instead of either being forced into a heroic narrative or back out with the invincibles. What a gorgeous way to think about the way we move in and out of that space, and how much we need one another to make sense of a world that is rendered absolutely absurd, where your mom accidentally says, oh, don't worry, I can take your son, because we don't know what it means anymore. But I found myself saying something that I can't imagine is true, and it is, but that for months I found myself saying, I don't want to go back. I just don't want to go back. And all I meant was, I just don't want to forget. I don't want to unlearn this thing I now know, where there are cracks in the world, and Leonard Cohen style, like all the light is shining through. And if I unlearn that, would I even know what it means to be human anymore? Anyway, you all know. You see it every day. But yeah, more of a gentler, a more graduated slope between this cliff we feel pushed off of. Always feels like the place then where meaning, that's what you all are describing, is the place then where meaning can be made of it. That's why I just love that you use the word suffering instead of just pain. What a better word. Gosh, palliative care, they always know. I feel like they should be in charge of all of us. Okay, Steve, I'm gonna just trail off now because I'm a little overwhelmed.
Okay. Karen Marsh, you have a great question for Kate.
Yes, Kate. So after your talk yesterday, I woke up like in the middle of the night with a question for you, and I'm so grateful to be able to ask it. You know, this idea of disappointment and forcing reimagining of care, the idea of disappointment forcing for all of us relearning and seeing the before and the after. I'm just so curious to hear you talk about like how you have reimagined God, you know, as a Christian, like how you have reimagined Christ and the act of Christ in your life. That's a big question, and I would appreciate hearing kind of where you are in that reimagining.
Yeah.
Thank you.
Well, yeah, I guess, and maybe we have different theological questions when we're in the midst of, you know, when we're in the fire, and then when we're just smoldering a little bit afterwards. But in the crisis of it, for me, the great unfairness was what I was grappling with. Just the why God do you seem to have such a high tolerance for evil? Why, after having studied miracle healing rallies for a decade, wouldn't you make yourself a little bit more plausible? I mean, why should I have to work this hard as a Christian to see evidence of your work in the world? I mean, if I could offer a few revisions, I would suggest something a little more obvious. Why do all your people seem convinced that they have to hype man you, stand beside you, explain to me how great heaven's going to be in order to make sense of my world for me as it is unraveling? I think the weaponized piety of the incredibly certain, if I wasn't a Christian before, that would have just leveled me. So for I guess the first bit, it was just why God, because am I not good somehow? Is my body not good? How do I picture this? Especially cancer. Like it's in me. It's kind of awful as a metaphor. It's still my body, but it's trying to murder me. Is it like a narcoleptic killer who's just asleep somewhere in the house, or do I need to get out? It was emotionally very confusing. But I think it became, it became something different when I let go more of the deep and misguided hope that I'd had that my Christian life would add up in the way, I was good. I mean, I know you're not supposed to say that as a Christian, but I was like a pretty good Christian. I was nice to strangers, and then when none of it would add up. I'm reading this lovely book right now. Dr. Sam Wells, he used to be dean of the chapel at Duke, and now he's at St. Martin in the Fields in London. But he has this, it's like a beautiful systematic theology, but it's reread as less about God being like, here's the instrumental ways that God works. He saves us from our sins. And granted, I am thrilled about all the four, but the God being with is the God that I've loved, the God that is in the warmth of the hand that always reaches out to hold mine after I'm wheeled into a surgery, and the one who is in my son's unbelievably uninterrupted childhood in the midst of pain, and the love that I now get to enjoy, when we get to talk about all of this, being people together. That to me has radically revised how I think about the God of presence, and that is God's great book of Job miracle, is that when all things are removed, God will be there. Even if we ask, where were you when the foundations of the earth were laid, right? God asks that. And we know he was there. So yeah, I guess presence has been where I landed.
So Kate, when we're looking at all of these doctors and healthcare and patients, where does the word hope fit in to all of this? There's so many moving parts. How can we talk about hope? How can we imagine hope?
Can we, because I've got these gorgeous experts in front of me. I love Steve's question. That's so great. I think about hope as God dropped as an anchor into the future, drawing me toward God, that a good story is not just the story where I get what I want in the end, but in God's redemption of the world. So when I feel hopeful, I try to disentangle it from optimism about my experience and think of it as a story of God saving the world. But you all have to face people and look in their eyes and deal with their diagnosis. So I wondered if Anne-Marie or Tim or any of you wanted to share how you think about hope in the face of suffering.
I'll take a quick stab at it, and first admit that I'm not a huge fan of the word hope. I think it can be a little loaded, and I prefer what Kate was alluding to, also of being with someone, and whatever that may be. And I'm going to contradict myself just a little bit, and then grab onto hope again. I think sometimes where we find hope is when we really widen out a little bit. And again, in medicine, I think we get really hyper focused on like an individual person. But what if we widen up even on what a life is, right? A life in the context of a family per se, and how even after someone dies, what is their legacy in that family? Like I'm always struck when talking to practitioners, to hear the story of how they got into medicine or whatever therapy, whatever it may be. And it's often tied to a personal story. Someone in their family had cancer, someone in their family committed suicide, and their career, their life is exists and inspired by that, what happened. And I think that's very transformative. And I do find a lot of hope in that. And I think sometimes we can find hope in tragedy in that too, the things that happen after. But you can't see this after story, which can be a story of hope, unless you really widen out. Sometimes I think we just have to let ourselves know in a really tragic situation that that potential is there, even if we can't see it in the moment, if that makes sense.
Thank you, Anne-Marie. Tim, in 2 minutes, can you tell us what you think about hope?
I love the word hope. And this concept I've really struggled with patients. One, offering false hope. I've come to understand the word itself is kind of, they don't know the origins of that word, but it probably comes from Germanic origins that means cul-de-sac. So you're hemmed in. And I think we tend to think about hope as an attachment to the future and an expectation of the future. But hope is a gift as I see it, and hope flourishes in the present. Hope is now. And it's really about the posture of your heart. If you can stay open and soft, open to the possibility of surprise, you can have hope until your very last breath. So I don't believe in false hope anymore, but I strongly believe in hope.
Okay. Any other comments from the panelists for just a minute about hope? So we've got just a couple of more minutes, Kate. So what question did we forget to ask you that you'd like to tell us in a final just a final comment for we're getting ready to close this down in just a few minutes. Just your final thought to this group of medical professionals. What would you like? What comment would you like to give with us?
And Taylor, did you want to add your thing about hope? I feel like you unmuted yourself, and that was also an act of hope.
Well, mine was just
yes.
After Tim spoke, I just thought that like I would like a Build-A-Bear version of Tim to like wake me up in the morning and be like, hope is now. Like I feel like Tim, like I believe you. I tend to be a little bit more like skewed towards Anne-Marie, but I'm open and I'm willing. And so it was just cool to hear somebody use that word and it didn't feel phony or fake. I felt like, okay, like if that's what hope is, like I'm down. So that was all.
Yeah. Well, I just, I guess I have found the kind of agility that these beautiful people are describing is something that I find so inspirational, is the ability to move between the like the deep end and the shallow end of between the transactional, this is the stuff that needs to get done, and the sort of existential challenge that this work creates. These are very emotionally expensive jobs and emotionally expensive postures toward life. So the fact that you all are not skipping any of it, but choosing to wade into the deep with all those of us who kind of just got thrown in the deep end, to me, is like the beauty of an interdependence that I didn't want and completely rely on. So thank you, my dears, for that kind of weaving together. I know that I count on it. And it gives me such a much richer intellectual framework than the hyper individualism that we're normally just handed, in which the best version is the version where we ought to do it on our own. So bless you all for your being with. It's the version of God I like best.
Hey, thank you so much for being with us. And if you guys haven't read it, this is just a powerful book, No Cure for Being Human. It really had an impact on me personally when I read it. And so, Kate, we appreciate the gift that you've been given of being such a wonderful writer and a speaker, and we so appreciate you spending some time with us today. We also thank our other event partners, Theological Horizons. Thank you, Karen Marsh and your team, UVA Center for Health, Humanities, and Ethics, Hospice of the Piedmont. And I want to remind you, as Tyson gave a big plug, and I agree with you, Tyson, if you didn't go to the lecture yesterday, please come online this Thursday evening at 7 p.m. You need to register, so you'll be sent the link. There's no cost for that. Just go to theologicalhorizons.org and click on Kate Bowler events, and there'll be a link to register for Thursday night. But a powerful talk, a powerful message, a lot of fun to listen to Kate. So I would encourage you to do this. And any other information you would like to hear about Theological Horizons, just go to their website. Okay, this has been a great hour. Thanks to everybody, and we thank all the participants for listening in. And we'll let everybody at the UVA Medical Center get back to work. Okay, thank you guys. Bye-bye.